equity. So I'm going to go through 4 ways that I've been thinking of that immunization reduces equities. So first of all, the poor have higher case fatality rates and sequela rates, so therefore vaccines are promoting disease equity. The poor have less ability to pay for treatment costs, so we are promoting economic equity. And also vaccination in many settings is an entry point, the first entry point to the health system for the poor, so we are promoting social equity. And lastly, we have specific vaccines such as cholera, neonatal tetanus, that are really targeting diseases of poverty. So there we have vertical equity intervention, where we're just doing special interventions for the poor. So I'll go through these 4 with some examples. And then lastly, I want to talk about the difficulties we really have in measuring this. This is also what we've alluded to already in the discussions. How do we actually measure these extra effects and not just mortality? So first of all, disease equity. So poverty, malnutrition is of course a great marker for poverty. So this is a study on the underlying causes of mortality due to diarrhea and ARI. And as you can see, those with the greatest malnourishment have much higher case fatality rates than the ones who are not malnourished. So 30% case fatality rate for diarrhea in the malnourished. This is a study of measles, so measles epidemics in Nigeria, Niger, and Chad. And again, so you can see the case fatality rates on the top, so high, very high in Nigeria, 12%. And in Nigeria, you can also see fewer were taken for treatment within 30 days after rash onset. So here we're really talking about limited access to care and the link between case fatality rates and limited access to care. And very high proportions paying for services. And as we know, this is of course a limiting factor of accessing care. The researchers were asking, you can see in the last column, the proportion of parents whose children died at home reporting lack of money as reasons not seeking care. It wasn't that high, but many of them, they were going to traditional healers, pharmacies. You know, it's not care that made these children survive. In a review of measles case fatality rates that I looked at, you can just see the clear link in developed countries. Kids are not dying from measles. So in this review, they sort of tried to say what case fatality rates we should use in different settings, and it's of course very linked to access to care. Apparently, malnutrition is not a big indicator of measles mortality, actually. There's not a clear link there, so I think access to care is really important. So now I want to talk about sequela rates that are also really, I was actually a little surprised by this, that they vary so much with access to care as well. So this is a review we've done of all the meningitis sequela studies. And in Europe, we found there in the bottom in the meta-analysis is 9%. So 9% of children suffering from meningitis were discharged with sequela, with disabilities. And in Africa, the number is 25%. So this is really about just getting late to the facility. So the later you present with your kid with meningitis, the risk just really increases for sequela rates. So that was about disease equity. So now I want to turn to economic equity. So this is really about treatment cost, how vaccines reduces treatment cost and how the cost of payment is just so much more important for the poor in society. So this is just showing you how, as we know, the treatment cost varies according to different settings. So in poor settings, the cost is just much less because services are cheaper and there's less access. And we see the same thing for pneumonia. So I want to talk about that in the poor settings, even though the costs are relatively low, what is the impact on the households? So we did a study in Kenya where we interviewed caretakers about how much they paid for pneumonia, malaria, and meningitis treatment, and we estimated the total cost of providing the services. So we found in this sample of 572 patients that user fees as a proportion, it was between 44% to 100% in mission hospitals. It was 40% in the government tertiary referral facility and 15% in the district hospitals. Then something happened that I didn't expect. I didn't know this. So in Kenya, you cannot get discharged without having paid your bill. So they have two things. They have medical discharge, which is if the child has recovered, and then they have administrative discharge. And you cannot leave without paying this thing. So we found a mother who stayed for 22 days waiting to pay the bill for, families to get hold of the money. And every day they stayed, they had to pay $5.32 extra. So, we're talking about catastrophic, and I know it's measured by the proportion of your annual income, etc. But I just think examples like this just show this is catastrophic. This is not some percentage of something. It's just that they had to stay for 22 days in this hospital because they didn't have the money. In the district hospital, 10% of admission remained for 2 to 3 days. And then in the mission hospitals, they allowed them to go even though they hadn't paid. They had some sort of credit offering facility so they had to pay back later. So this is a study we did about the cost of meningitis sequela. So this is when I worked a lot on hip vaccine, because hip vaccine in high-income countries was actually mainly introduced due to the high cost of sequela. In all those cost-effectiveness studies, it was the cost of sequela, the cost of rehabilitation of children suffering from sequela that really drove those results. But we didn't have any evidence in low-income settings about what does it actually cost when you have a disabled child. So we did this study in Senegal. So the objectives were to estimate the household treatment costs just of the acute episode, the healthcare seeking behaviors when you have a child with disability, estimate the cost of having this child, pay childcare, and the productivity loss from caring for the child. So these were the objectives. So what we did, there was a database in a tertiary hospital in Dakar with children that had suffered from meningitis. And then we were tracking these kids down. So some of them, I think the highest was 7 years after discharge, we managed to find them. So this is just showing you how we found them. And in the end, I have data for 46 children with treatment cost data that we managed to interview, and they were suffering from disabilities. I thought it was interesting. So we found 19 children that luckily didn't have any disabilities, but actually thought it was interesting. When you're just talking about one deafness or one neurological sequela, there were so many that had multiple types of disabilities. So one had 7 types of disabilities. So the acute episode, it wasn't really meant to be part of the study. This was a sequela study, but we collected the data, and it also tells a lot, because what we found was when the kids got ill, it took a long time before they went to the hospital because they have to pay. So they went to all sorts of different places. I have data on that as well, before they finally went to Albert Royal. So 70% of children had gone at least somewhere else. The mean length of stays was 22 days. One child stayed 88 days. And this is the mean treatment cost that the parents paid, $1,289. So this was just hard. I just have some quotes, how they had to find this money. During hospitalization, we spent much money because the prescriptions were expensive. The injection was very expensive with the cost of $16. I was obliged to take heritage of my deceased father, but this was not enough. God assisted us. I borrowed some money from a friend, but I only managed this situation with difficulties because I was unemployed. The hospitalization was a heavy financial charge, and now we haven't got household expenses. I used my only money for the child's treatment. So, we weren't meant to collect data on the episode, but a lot of the parents just talked about how expensive it actually was to have the meningitis treated. And this same thing, in the end, my parents assisted me to buy the prescription, and I sold all my possessions. So this was just the acute episode. So the cost of the study was the sequela cost. But what we found, none of them were accessing care, so there was nothing to cost, right? It doesn't cost anything if you don't go anywhere. So some of the children had gone to physiotherapy and places, like lots of parents would like Cochrane implants for deafness, but it's just too expensive. So we really had nothing to cost. You can see rehabilitation, rehospitalization, there were a few children. The mean cost was $275. Lifetime outpatient visits, because they had gone, like especially in the early days, but they just stopped. And then I had lifetime childcare, which was people looking after. And then 81% of the household said that one person couldn't work because they had to look after the child. And then we asked, so how much do you think you could have made in money if you could work? And that's what we used to estimate this lifetime productivity cost. So again, for the acute, is that catastrophic? So the mean cost that they actually paid, it actually exceeded the annual income of an informal sector worker by 41%. And the mean cost of one outpatient consultation is equivalent to 36% of a monthly salary. Okay, this is just quotes again about sequelae, why they can't work. Okay, so now about social equity, how vaccines promote social equity. So this is about, I think in some settings, vaccination is really one of the fewer health interventions, especially in Senegal, for instance, where they just have to pay for everything. At least you don't pay for vaccines. So that's promoting that entry point to the health system. And in some settings, I think we often undervalue just the vaccination card, which is often extended to other, like growth chart, etc. It's like one of the only records mothers have of their child's existence. And in some countries, this is being linked to birth registration as well. In Burundi, they have linked it to birth registration. It's extremely important to have your child registered. There is a study trying to look at the effect on actually having the card. Because in Kenya, for instance, the card has, say, it's like a little book, and it tells the mother how to treat and etc. So there was a study about whether there were differences, whether you had a card or whether you didn't have a card, and they actually found significant differences between proper health-seeking behavior. They were asking them, when your child was sick, what did you do? And they found significant differences with fever and diarrhea treatment. So lastly, the vertical equity issue. So I think one of the clearest example we have at the moment is MNT Elimination. So this is about neonatal tetanus. This is really children being born at home in very dire conditions. And as with polio, the deadline has passed. I can't even remember when it was meant to have been eliminated, but now it's 2018, I think, the new deadline. But there is good progress. I'll show you a map next slide. But the strategy for doing MNT elimination is really, of course, strengthening routine, but also doing campaigns, ensuring that mothers, like women in the reproductive age, receive at least 3 properly spaced doses of TT vaccine. So we only have 18 countries yet to eliminate, and there are some of, like one of them is Haiti, where they just couldn't do the certification because of the a cyclone. So some of these 18 are really just about to be certified. So there are very few countries left. So I think MNT is really an example of where you're just targeting the poor, and it's a vertical equity intervention. So my last slide is just about some of the measurement challenges I think we have. So for the first one, disease equity, it's just harder to estimate the case fatality rates and the morbidity in settings where there's so limited access to care. It's just basic surveillance issues. The economic equity, as I mentioned, when they don't access care, there's just no cost to measure. So that one is just hard to get a handle of. And the social equity is just largely intangible. It's very hard to measure the value of having registration and just having an entry point. And I actually think with the vertical equity intervention with the maternal neonatal tetanus, it's also really hard to measure what is the value of that, because again, there's no money involved in these mothers are delivering at home, and if the child died from tetanus, it's never going to be registered. So we have big measurement challenges. I know from neonatal tetanus interventions elimination initiative they have big problems sort of communicating the value of doing it, even though it seems obvious to us. When there's no hard numbers on it, it just limits it a bit, and it's hard to measure. Thank you very much.